going to go on and invite our next speaker, Associate Professor Adam Irwin. He is a Principal Research Fellow in Paediatric Infectious Diseases at the University of Queensland and Queensland Children's Hospital in Brisbane, Australia. His research focuses on the early recognition of invasive infections and sepsis and the optimal use of antimicrobials in children. And we're going to have an interesting case. Thank you.
Thank you, Kathy. And it's perfect to follow Holly. And nice to see that I've only nicked about 2 of your slides. So hopefully there won't be too much overlap. So this is going to be a clinical case, the case of the first child treated with bacteriophage here in Queensland. But relevant to this session, it's also a case that's difficult to treat, multi-resistant infection with a little bit of antibacterial therapeutics thrown in for good measure. Let me just start by acknowledging the traditional custodians of the land, that the land on which we are meeting today in the southeast corner of Queensland, the Turrbal and Yagara peoples. And I'd like to pay my respects to elders and descendants who continue important cultural and spiritual connections to country. I'm pleased to hear that you've already had a couple of talks relevant to children this morning. But when I present to a mixed audience of this kind, I think it's really valuable to establish some basic principles of pediatrics. This is a child. This is a child who you'll see has an intravenous infusion running, but is still pursuing his dream of working towards his first century at the G for England. This is an adult. And you'll see the thing that I like about pediatrics is children are still pursuing their dreams while adults are waving baubles around. So this then is the case of a 13-year-old young man with B-ALL, who we'd first met with an MRSA line infection, but the start of this story really is with him presenting with an acute abdomen and febrile neutropenia. And he was diagnosed with terminal ileitis, and his bloodstream grew an E. coli with this phenotype, multi-resistant E. coli, resistance to aminoglycosides, to quinolones. And he was diagnosed and managed as an E. coli BSI with some empirical PIP and aminoglycoside, cefepime for a week, and ceftriaxone for a second week, about 2 weeks of IV therapy, roughly consistent with the treatment of an E. coli BSI and a febrile neutropenia kid with an abdominal source. But a month later, he presented acutely with, again, febrile neutropenia, and this time with pain in his knee, and was diagnosed with an osteomyelitis. And when he went to theatre, we identified pus in the bone, which cultured E. coli, and the E. coli, to all intents and purposes, was identical. And you'll just notice that the cefoxitin was identified to be resistant on this bone isolate, on this bone strain. And the implication of this was that we were recommended that this was likely a multi-resistant non-ESBL plasmid AMP-C producer. And this, of course, had implications for us because it then meant that we were pushed along the line of treating with either IV cefepime or IV carbapenem. And for an osteomyelitis in a child with neutropenia, that was likely going to mean a prolonged duration of IV therapy on HIF. And so that's what happened. He had 2 weeks of IV meropenem, was switched onto ertapenem, and unfortunately relapsed shortly into his HIF presentation, needed to come back in once more for source control, grew E. coli in the bone again. And so then we extended his originally planned 6 weeks of IV therapy to a roughly 4-month course of IV ertapenem on HIF. And we really didn't believe that we had any oral options available to us. So in around about August of that year, his antibiotics were finally stopped, but a month later, post-antibiotic cessation, he came back in with bogginess over the tibia, confirmed OM on imaging with a sinus tract, and went to theatre, and we grew again the same E. coli. And this time we worked it up genomically, and we could see that the E. coli now in October was identical to the E. coli that we'd cultured earlier in the year. And the other thing to note is that this was a TAS-resistant ceftriaxone susceptible isolate. And when we sequenced the isolate, we discovered that this was the mechanism of the resistance here was a narrow spectrum beta-lactamase, a TEM1 mutation, the presence of a TEM1 beta-lactamase with a mutation in its promoter region, which leads to hyperexpression of this narrow spectrum beta-lactamase. And this is consistent with a recently published series from Liverpool, where they sequenced around about 70 of these E. coli, peptide-resistant ceftriaxone susceptible, and saw that this TEM1 beta-lactamase was present frequently with in the presence of a promoter gene, which conferred an hyperexpression of the TEM1 beta-lactamase that you can see here. What that meant for us, though, was that this isolate was likely to be amenable to treatment with ceftriaxone. And so following this second clinical relapse, we were able to switch him from a carbapenem onto ceftriaxone, which made at least his home therapy easier. And over this period too, of course, this is when we started the process of working up his isolate for phage therapy. And we are contributors at Queensland Children's Hospital to the STAMP study. There's one of the slides, Holly. And so we contacted Holly and the team to help us identify a suitable phage candidate or cocktail of phage for this boy's treatment. And so just like Holly illustrated before, on the spot test, we identified 2 candidate phage that seemed appropriate to our E. coli isolate. And at least the EC33 was highly efficient, and we saw lots of phage amplification in the presence of our clinical isolates, less so for EC70, but still pretty substantial phage titers. And the growth of E. coli was significantly impaired in the presence of EC33, EC70, or a combination of both. So we thought that we had a candidate phage cocktail. Inevitably, this process happened at the back end of the year and into the Christmas period, and so he continued on his IV therapy, and in the early part of the year, we brought him back in. It was necessary to bring him into hospital to give him an intravenous phage course, at which time he was perfectly well. And we felt like perhaps we had missed the boat. We had some discussion about how seriously we thought this boy had ongoing infection. I remember a clinic appointment with him where we were having to tell him off for jumping on a trampoline with his avascular necrotic bone. But still, we brought him in and we administered phage for 2 weeks. These are the phage kinetics that Holly's team, Steph, I think, provided for us. And what you can see is that this demonstrates amplification and a lytic infection. And you can see in the cases that Holly referenced, the phage PK and the phage titers were anywhere between 10 to the 2 and 10 to the 4. And what you can see here is at least in EC70, we've got phage titers at 10 to the 5 and 10 to the 6, really significant phage titers in his blood. Certainly suggestive of a productive phage infection. That's the second slide. But post-phage, we stopped his antibiotics. 2 months later, he came back in with an acute abdomen and acute cholecystitis. We think the cholecystitis was likely triggered by his prolonged ceftriaxone use. Because he came in with an acute abdomen, inevitably he got IV meropenem empirically. And during the course of his admission with an acute abdomen, his bone relapsed again. And he had to go back to theatre for another extensive infection of his proximal tibia with sinus tract formation, which which meant that we had to restart his therapy, and we went back to treating him with IV ceftriaxone. And the hypothesis was that this is avascular bone, which is extremely difficult to treat with systemic antibiotics. So he continued on a further 6 months of IV ceftriaxone, at which point we repeated his imaging, but unfortunately still showed this hotspot in his proximal tibia. And with that hypothesis in mind, we discussed with the surgeons again about what more could be done to try and debride this bone. And the surgeons took him to theatre at the end of last year and debrided as much of this bone as they thought was practical. And then at this stage, we thought we might like to try, if we've been struggling to treat him with systemic intravenous therapy, we might like to try to give him an oral tail, which would mean that we could take out his central line. We knew that in vitro, at least, cefixime would be an appropriate antimicrobial, but there really were no data other than for UTI. And of course, we believe that oral fosfomycin would be a likely very effective antibiotic against this E. coli, but it's not recommended, certainly not an oral preparation for a systemic infection or a bone infection. And the thinking being that you really don't get adequate systemic exposures with oral fosfomycin. We wanted to question that established thinking, and so we brought him in, keen to give him an oral preparation of fosfomycin in combination with cefixime. And we tested we performed therapeutic drug monitoring at hour 2 and hour 4, post-administration of a good dose of fosfomycin, 6 grams every 8 hours. But what we demonstrated was an AUC over MIC, which was highly likely to be effective for this organism. And so we're now nearly 2 years into treatment. He continues on his fosfomycin and cefixime. He's perfectly well as far as we can tell. In another 3 months or so, we're likely to bring him back in and repeat his imaging in the hope of stopping his treatment. And we'd be keen to hear your thoughts on his management. Thank you.
Thank you, Adam. Grateful that I'm adult physician because all the challenges adding the child jumping on the trampoline was a bit stressful.